to everyone. I'm very pleased and honored to be a part of such an excellent meeting and with such distinguished presenters, what I'm very thankful the organizers for. I'm Tatjana Ladenhauser. I'm internal medicine specialist and I'm a medical oncologist working in Osijek, Croatia at oncology clinic. And I will say something about the role of an oncologist in the treatment of NETs. You all know and aware that those are rare diseases, and within the oncology circles there is very few new things to say, but is it really nothing to say about those diseases? Let's take a look at the Croatian Medical Oncology Congress, which was held in 2019. There was the last lecture on NETs in last 5 years. If we look at the congresses, regional congresses of medical oncology held in Dubrovnik, Belgrade, Sarajevo, and Ljubljana, there were also no lectures on NET tumors. But elsewhere, we can see that this year's Oncology Congress held in Barcelona, there were 137 topics from educational lectures to poster presentations about NETs, and those 4 educational sessions were about NETs. Why is it so? Because NETs are rare diseases. They are very heterogeneous in clinical presentation and tissue sites. Their incidence is relatively small, but it is increasing during last few decades. Very large proportion of patients are diagnosed at advanced metastatic stage, from 60 to 80%, because their symptoms resemble other clinical conditions. And there are also very few treatment options. One study found out that median time to diagnosis from first symptoms are 36 months for small intestine NETs and 24 months for pancreatic NETs. Before their final diagnosis, this study finds out that patients will see their GP or specialist 7 to 8 times, and 31% of patients are diagnosed at emergency visit from some cause. So the color of the ribbon for neuroendocrine tumors is a zebra pattern. Why the zebra? Because obvious, when you hear a sound of hoofbeats, that means there is a horse. But in NETs, it's the zebra. It's the less expected situation. I will shortly present the classifications of the most famous oncology societies, that is European and American. Here we see the ESMO classification of neuroendocrine tumors, which I will not speak about everyone, but of gastroenteropancreatic and lung and thymic carcinoids. We can also see that here is Merkel cell carcinoma. This is a very aggressive tumor of the skin, and other rare endocrine tumors of head and neck region, genitourinary, gynecological, tumors with unknown primary, and so on. This is the American classification, which is a bit more complex than European. Very important, as we have heard before, is that the accurate grading of the tumor sample is obtained by pathohistology. So, as we already heard, there are NETs grade 1 to 3, which are well differentiated. They are key in 67 index thresholds being at 3, then 3 to 20, and more than 20%. Those cancers, which are large cell and small cell, they have much more higher Ki-67 index than 20. It is above 55%. Some is different, the classification of lung neuroendocrine tumors, which are classified as typical carcinoid, atypical carcinoid, and large and small cell lung cancer. Here is one presentation of on how the grade influences the overall survival in patients, where we can see the curves for event-free survival and for disease-free survival, where we can see that survival depends mainly on the tumor grade. So where is the role of an oncologist? Our role is, of course, at inoperable and metastatic disease, where we are deciding about upfront treatments. Sometimes we should consult surgeons about resecting the metastatic disease, which is confined to liver, if possible. Surgery is not for disease outside the abdomen and not for high grades, especially not for neuroendocrine carcinomas, grade 3. Sometimes surgery can help the patients with obstruction of gastrointestinal tract by debulking, or it can relieve symptoms in functioning GP nets. Sometimes we can consider some patients for liver transplantation, especially if they are grade 1 to 2, with a lower Ki than 10%, and with obligatory previously removed primary tumor. Those patients must respond to therapy at least 6 months. But our main role is medical therapy. I will stress now out that there is no role of adjuvant oncologic therapy in G1 and 2 tumors, but it is an obligatory procedure after resection of grade 3 carcinoma tumors when we give a platinum-based adjuvant regimen. So a goal of this therapy for metastatic disease is control of tumor-associated symptoms and control of tumor growth. You all know, and we all know, that we need to control the symptoms. These are relatively complex schemes of SSTR positive and negative tumors. We see that first line in tumor symptoms control is SSAs, with octreotide being the main drug, because lanreotide is not available in Croatia. We can reach out for interferon alpha or some debulking surgery, and when this is not enough for control of symptoms, we can increase the dose of SSA, or we can increase the intervals, or shorten the intervals between doses. We can add interferon, or we can reach for some other SSA, for instance, pasireotide, which is off-label use in this indication. Those formulas, as I said, are standard first line for functioning nets, and they improve end flushing and diarrhea in majority of patients. Where the symptom of carcinoid syndrome are worsening, then we can increase shorten the interval, we can increase the dose. Alternative is pasireotide. We can use telluristat ethyl for control of diarrhea. We can transfer patients to PRRT. Everolimus is not for symptom control, but we will see later for what it is for. Our main role is anti-proliferative treatment of patients. There are unfortunately no predictive factors for therapy selection in this patient population. It depends on pathological and clinical features, on tumor extent and growth behavior, and of course on SSTR imaging. We use targeted drugs, we use systemic chemotherapy, and none of these drugs are curative, but they can provide disease stabilization. About SSAs, we all know that it is a good tolerable drug with very few side effects. It is for SSTR positive tumors, but its status does not predict the response to SSAs. Everolimus is something we use for further lines for progressive G1 and 2 pancreatic nets and for same grades of other non-functioning gastrointestinal nets. It is used for lung nets. It is used already, but not recommended with SSA, except for functioning pancreatic nets. But this drug has very frequent side effects such as stomatitis, diarrhea, fatigue, infections, pneumonitis, and hyperglycemia. And we often experience the needs of drug interruptions or dose modifications. Then there is a drug called sunitinib, which is multi-kinase inhibitor approved by the EMA and in the States for G1 and 2 pen nets. It also has frequent side effects as diarrhea, nausea, asthenia, and vomiting. And it can be used either on treatment-naive or previously treated and progressive patients. What about chemotherapy? We also use it in nets, for nets of grade 3 of any site. It can be useful if the Q67 is from 15 to 20%. It depends on clinical decision. The drugs that are used are streptozotocin and 5-fluorouracil, then temozolomide-based chemotherapy alone or with capecitabine. And for grade 3 next, we use cis or carboplatin with etoposide combination, regardless of primary site. But crucial for outcome for those high-grade tumor patients is very early treatment onset and very aggressive immediate treatment. Otherwise, they do not have good prognosis. I put this scheme for our drugs that we can use in small intestine nets, pancreatic nets, and neck G3 of any origin. I will not speak about every one of them. I will also mention that we can refer patients to PRRT, which is option for progressive nets. It is said that lutetium-177 isotope is preferred over yttrium-90 labeled SSA, and this isotope, which is added to octreotide, it really improves the symptoms. It prolongs the PFS and it influences the quality of life of those patients. One very unfortunate adverse event of this therapy is irreversible bone marrow toxicity, which happens in 3 to 4% of patients. We have to count on that and have that in mind. And larger percent of patients will obtain mild renal failure with this procedure. After complete resection, patients needs to be monitored by biochemistry, by SSTR imaging, and with CT or MRI. Some nets do not need further evaluations and monitoring, and those are small GI1 appendical nets. we will sometimes need to refer some patients to genetic counseling for the cases of adrenocortical carcinoma, paraganglioma, and pheogastrinoma type 2, multifocal pancreatic nets, and parathyroid adenomas, and so on. And what is new in oncology and oncologic treatment for those patients? Something is here, what we heard at this year's ESMO Congress, which are results of cabinet study that was randomized phase 3 clinical study of cabozantinib versus placebo in earlier pretreated progressive NETs. They found some novel biomarkers for prediction of response to TKIs, for example, osteopontin as negative predictor to TKIs. And I have to mention the results of LUNA phase 2 studies from 2017 and 21 in progressive lung and thymic carcinoids. This was the study design of cabozantinib versus placebo in pretreated NETs. Primary endpoint of the study was progression-free survival, and secondary overall survival, objective response rate, and safety. And what was shown that extrapancreatic NET cohort with cabozantinib had advantage in median PFS, 8.4 months versus 3.9 months on placebo, and this advantage in PFS was even better for pancreatic NETs, where the risk of progression was set to 90 and not 90, pardon, 77%. Their PFS cabozantinib group was 13.8 versus. There are also some other TKIs which are investigated in phase 3. Earlier mentioned cabozantinib, then axitinib, which is an ongoing, but results are not yet published, and this surufatinib, which is approved but in China. And there are another studies of efficacy and safety of long-acting pasireotide or everolimus alone or in combination in patients with advanced carcinoids of the lung and thymus. It was also an open-label, multi-center randomized phase 2 trial. It included 124 patients from 36 centers in 9 countries, and the groups were divided in everolimus group, pasireotide group, and combination group. They have looked at overall response rate after 9 months, and it showed that overall response rate is really significant in the combination group of pasireotide and everolimus of 58.5%. The study met its primary endpoint in all 3 treatment groups. And there is also long-term results published in 2021. Those were the patients from extension phase of the study after 12 months of treatment, where there were 41 patients who entered this extended phase. And also here, the combination of PAS and everolimus showed clinical benefits in PFS and biochemical PFS. Here was another interesting study, phase 3, with pasireotide, long-acting release in patients with metastatic tumors and carcinoid symptoms refractory to available SSAs, which where pasireotide was compared to octreotide LAR 40 milligrams, And also we can see the advantage in the group of pachyreotide patients in survival probability. Now I would like to present some of our local situation with NETs treatment. So I found that in past 2 years we treated 28 patients with metastatic NETs with carcinomas being excluded. They were 18 of them females, 10 males. A median age at diagnosis was 66 years, ranged 40 to 80. Most frequent primary localization was the small intestine, 32%, then pancreas, lung, unknown primary colorectum and appendiceal 1 patient. Most frequent grade was grade 2 in 64% of patients, then G1, and the smallest proportion of patients was, as expected, G3. We've found that serotonin hypersecretion was present in 9 patients who had the primary ileal, pancreatic and lung NET. We also had 1 patient with elevated PTH and ACTH, and 1 patient had hypersecretion of aldosterone. It was patient with unknown primary tumor, but probably adrenal. Most common metastatic sites of our patients was liver, abdominal lymph nodes and lungs for small bowel NETs, then exclusively liver in pancreatic NETs, then lungs, liver and mediastinal lymph nodes and bones for lung NETs. Unknown primary had liver and bones metastasis. This last number is very horrifying, but it is, as I said before, that a very large proportion of patients are diagnosed at metastatic stage. So was the situation with our patients, where 22 of 28 of them had initial metastatic disease. And we treated them with first-line octreotide LAR, 30 milligrams in 25 patients. 1 patient got SSA with everolimus in first line. This patient had lung NET, and we gave chemotherapy captain protocol in 2 patients who had G3 tumors. After progression, we are using to increase the dose of SSA to 40 or 60 milligrams in 11 patients. Sometimes together with increasing dose, we add another agent, and that's what we did in 7 patients. We added Captem or everolimus. We sent 2 patients to PRRT procedure in Germany after progression on SSA, and both of them had good disease control afterwards. We used other regimens. Those are Captem, platinum etoposide combination, etoposide monotherapy, or FOLFIRI protocol. In last year, average of 32.3 per month injections of octreotide 30 milligrams are given to approximately 20 of patients, and adverse events, there were not many. Those were only pain and swelling locally, because this drug, which is given intramuscularly. 2 of those 28 patients died, 1 from liver insufficiency and carcinoid heart disease. It was ileal metastatic NET grade 3, and 1 patient died from liver insufficiency who had rectal metastatic NET grade 2, and both of them were treated with 4 or 5 therapy lines. Problems and challenges with the medical treatment of those patients are that they share the fate with other rare diseases. We might say even orphan diseases, because there are some how forgotten diseases in oncology. They have many different primary sites, so there is no code in international classification of diseases. Some of those patients are long-term treated and at 2 or more oncology centers. There is no standardized treatment algorithms, no novel therapies, no clinical studies. Some even drugs are not available in Croatia, as well as PRRT. And we have a problem that is often undetermined hormonal status, especially for pancreatic NETs. We surely can do something better. That is the strengthening of cooperation in MDTs with endocrinologists, with specialists in nuclear medicine, radiology, and so on. We need to improve our local algorithms, conduct some registries perhaps, and to publish our results. And I'm very thankful for your attention. The management of NANS lies in teamwork and team cooperation.